A 15-year-old male presents with localized back pain. I am showing you the lateral radiograph of the lumbar spine. Describe the findings.
Okay, looking at the images, the lateral radiograph demonstrates uniform collapse of the fourth lumbar vertebral body into a thin, flat, sclerotic disc. The adjacent intervertebral disc spaces are completely preserved, showing no narrowing or degeneration. The posterior elements of the affected vertebra appear intact and are spared from collapse. There is no significant kyphotic deformity or associated paraspinal soft tissue mass. These features of vertebra plana in an adolescent are highly suggestive of an eosinophilic granuloma.
What is the differential diagnosis for a vertebra plana, and how does it differ from platyspondyle?
Well, the differential diagnosis for a vertebra plana includes eosinophilic granuloma, idiopathic avascular necrosis or Calvé disease, infection, trauma, steroid-induced osteopenia, hemangioma, and neoplastic infiltration such as leukemia, lymphoma, or metastases. In contrast, platyspondyle refers to a congenital flattening of the vertebral bodies from birth, rather than collapse of a previously normal bone. Platyspondyle is associated with skeletal dysplasias like thanatophoric dwarfism, osteogenesis imperfecta, Morquio's disease, spondyloepiphyseal dysplasia congenita, and Neist syndrome.
Describe the clinical course and characteristic radiological presentation of eosinophilic granuloma of the spine.
Okay. Eosinophilic granuloma, the localized form of Langerhans cell histiocytosis, has a predilection for the thoracic spine, but can involve the lumbar and cervical regions. Radiologically, it classically presents as a solitary collapsed vertebra with a flat, coin-on-edge appearance. Early in the disease, the vertebra may show an osteolytic lucency before progressive, uniform collapse occurs. During the healing phase, which takes several months to years, there is often partial or near-complete spontaneous reconstitution of the vertebral body height, which is a key differentiating feature from neoplastic collapse.
What radiological findings would raise suspicion for a malignant or infectious etiology rather than eosinophilic granuloma?
An infectious process, such as pyogenic or tuberculous spondylodiscitis, would show destruction of the adjacent intervertebral disc space and end plates, often with a paraspinal or prevertebral fluid collection. Malignant processes, such as metastatic disease, lymphoma, or leukemia, typically involve multiple vertebral levels, show osteolytic destruction of the posterior elements or pedicles, and demonstrate a bulky epidural or paraspinal soft tissue mass. Eosinophilic granuloma is characterized by sparing of both the disc spaces and the posterior elements.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this radiograph with prior studies to evaluate the rate of collapse. I would strongly recommend an MRI of the entire spine to confirm that the adjacent discs are spared, evaluate for any canal narrowing, and rule out subclinical multi-level vertebral involvement. I would suggest a skeletal survey or a low-dose CT of the skull and long bones to search for other osteolytic lesions of Langerhans cell histiocytosis. Finally, I would document the findings, communicate them to the pediatric oncology and orthopedic teams, and recommend a tissue biopsy if there is any atypical feature or diagnostic uncertainty.